The charting system has enabled us to develop new means of treatment to get the chart back to normal to help couples who have different problems. The idea that a chronic low-grade infection adversely affects your fertility and causes miscarriage as well as premature delivery isn't widely known. We haven't published on it apart from the textbook, but we know it in clinical practice. It's imperative on us, we've got a moral obligation to publish on it, to try and get our peers looking at this kind of a thing. We've also recognised that in this other case, it was actually immune-modifying treatment that was needed to get a normal charting pattern. So we've got a system that gives us direct feedback to let us know, is our treatment working in this case or not? And it's all based on the simple observations that the woman does that she also uses from family planning. So the signs have to return to normal so that we know that we've got optimum preconception environment. Part of what we do is timing of blood tests, and without going into it in detail, I'm just trying to give you the concepts today. Timing of blood tests is everything. If we know where the woman ovulates, we time her blood test. The traditional concept is if you do a day 21 progesterone blood test, then if the level is low, you're not ovulating at all. And it's an absolute, yes, you're ovulating, no, you're not ovulating. That's how it's interpreted. We have a different interpretation. We time the blood test, we use a higher reference range, and if the blood test doesn't reach our target reference range, we'd say, well, look, you might be ovulating, but you're ovulating poorly with suboptimal hormones that's going to put you at increased risk of infertility and miscarriage. It's a new concept. So we don't have the all or none interpretation, we've got a different one, and it changes the way we manage our patients. That's one of the key things for physicians to understand. Because a lot of the time we get patients coming to us and they say, my GP told me my hormones were normal, but you're telling me looking at the same blood result, you're saying they're abnormal, and that's why. We're actually both right. The GP is right that it's normal for a day 21 blood test result, but for our reference range and the way we interpret it, 7 days after ovulation, in fact, we'd interpret it as low. The other thing, we look at ultrasound, but the other one is seminal fluid analysis, which causes a lot of conflict from a Catholic perspective. We use perforated seminal fluid collecting devices. It's like a condom that the man wears during intercourse, and it's perforated so that when the seminal fluid is released, some of it gets through the perforated condom, so it's not a contraceptive act, but the majority of it is retained within the seminal fluid collecting device, and you can analyse it in the laboratory. So seminal fluid samples can be collected in a way that doesn't infringe on Catholic medical ethics. I've been well advised by Professor Vincent Toomey on this one, as well as other moral theologians that were in keeping with Catholic medical ethics. As it turns out, most of the time you find what is morally good is also medically good. You get better samples this way than the traditional method of collection. It's a more reliable sample, and you don't have to get the guy to repeat it 2 or 3 times. So faith and reason, in my experience, always go hand in hand, and good morality makes for good medicine. Surgical assessment is really important. We're blessed to have an excellent surgeon in Dr. John Monaghan in Portiuncula Hospital, Ballinasloe, and I'll tell you what, the results that we're getting today, we would not get them if it was not for his surgery. He has trained in the NaPro Technology surgical techniques. We have a new surgeon just trained in those techniques joining us in the Galway clinic, Dr. Eileen Riley, and there are a few new gynecologists who have just come into the country who are doing really good surgery as well. So I'll refer to any surgeon that does really good surgery, but it's really important for success. And one of the key things we find is the incidence of endometriosis. In Professor Hilder's experience, 75% of his patients have it, whereas the national average in the United States is like 1/10 of that, about 7%. So he's 10 times more likely to see endometriosis compared to your average gynecologist. It's the same experience here. You need to be specially trained in these techniques to correctly identify as well as treat endometriosis, and that's a key thing to getting a successful pregnancy. Once we identify all the problems medically and surgically, we fix them, and once they're fixed, then we say, okay, now you need to be relaxed, healthy and happy. So our goal is, if you want to get pregnant, we need you healthy, we need you happy, and then we want a good chart with good hormones, and let it run for 12 cycles, because it can be normal to take up to a year to get pregnant, and if they're not pregnant after 12 cycles, then we start to think, maybe this isn't going to happen for you. And sadly, despite the good results that we're getting, it doesn't work for half the people I see from an infertility point of view, and it's really important to remember that as well. Much and all, as I celebrate the success that we get, it pains me for the people that I see that despite my best efforts, we don't get a successful pregnancy for them. And these people will always be there with us, and it's really important. I had thought when I would treat couples with all of this, if it didn't work, that they'd be really angry with me and say, you know, this didn't work, and they'd be really cross. But the opposite happened. And again, they felt they were treated with a measure of respect and dignity. We spend 45 minutes per consultation. We spend a long time with them. We develop a relationship with them. We're in contact on a monthly basis with their blood results. We empower them to understand what we're doing and why we're doing it. They're partners in the fertility care. I'm like their coach, and they're the ones who do it. So when it comes to creating the child, the couple co-create together with God, but it's like I'm somewhere in the background where I've done something to facilitate that, to make it more likely to happen. So it's still between them as a couple and God, but sometimes it won't work. And these couples that it didn't work for, they would often talk about the benefit that the whole experience has been to them, which for me was a very pleasant surprise with it, because I would see people the other end of failed IVF, and they're broken people. And so even that's one measure of success that isn't really documented in the figures from our study, is the success that people weren't traumatized as a result of going through the experience. Generally. Now, there are exceptions, so we do the best we can, but some people will still find it traumatic despite us doing our best, and some would still be dissatisfied, but the majority would be pleased and recognize that we've done something good and we gave them the best chance we could. We always remind couples, remember, a child is a fruit of your love, not your labor. And the more you labour at it, the less likely you are to get pregnant. At least 50% of the couples we see that are pregnant, and they come to us for their scan, they tell us, funny, that was the month we only used one day instead of every day. That was the month we decided we were going to quit, and so on. But it was very much where it became more about them loving each other, and it became less about the result, and next thing it happened. So that's a thing we try to explain to couples really early on, and that a child is a fruit of their love, not their labour, and to stick with it for the 12 cycles. NaPro Technology requires a revolution in gynecologic thinking. Infertility isn't a problem after 1 year of trying to conceive. Infertility is a problem even before you attempt conception. Miscarriage isn't a problem after you've had 3. Miscarriage is a problem even before you attempt conception. This is because we can look at the fertility care chart and see it from the chart before it even happens. And if you know anyone who's experienced the emotional pain of miscarriage, you realise what a tremendous potential benefit this is, not just for faithful practicing Catholics, but anyone who can benefit from it. Fertility, again, is not a disease that needs to be suppressed or treated. It's a normal, healthy process that we can understand and live in harmony with. When couples come to us and ask, are they suitable, some couples that we can't treat are, if you've already entered the menopause, we can't help you. There's no eggs left, and there's nothing we can do about that. If your tubes are both blocked, despite attempts at surgical reconstruction, we can't help with that, or if there's no sperm there. But barring those situations, that would exclude about 5% of all couples that would contact us. The vast majority we can help. But we have helped those on the verge of menopause. Anyone who's medical will recognise what FSH is, but if it's above 10, 10 is normal, and usually you're considered around the menopause once it's 30. We've one couple expecting at the moment, her FSH is 32. We had another couple who had no period for 6 months, and she's had a successful pregnancy with us. We've had couples with blocked tubes that we've surgically reconstructed and achieved successful pregnancies, and severe male factor infertility with very low sperm counts, we've helped them conceive as well, and over 160 couples with IVF, with previous failed IVF before coming to us. And in fact, with NaPro Technology, we can often achieve success where IVF can't work at all. If you're on the verge of menopause, IVF is no good to you. We've got loads of couples that we can help conceive in that scenario. IVF doesn't help for unexplained recurrent miscarriage, and we can. Chronic low-grade infection isn't even detected, let alone treated with IVF, whereas we can because of our fertility care chart. And immune-modifying strategies, Some IVF clinics are starting to do that, but it's very much integral to what we do. So there are many situations, we're often told, well, with severe male factor infertility, you can't help, an IVF can. In some cases, with both tubes being blocked, we can't help, an IVF can, and a couple have a choice to make then. Do they want to go for artificial reproductive technologies or not? So we'd recognise, well, okay, there will be cases where IVF may be able to offer success where we can't, but is that a road you really want to go? Miscarriage. It's not just about eggs, it's fertilised eggs, it's eternal immortal souls, and it's a lot of pain. And this is one couple who had 6 recurrent miscarriages, and she came to us in 2004, and she was aged 40. So I won't go through all the details because I know time is a bit of a pressure thing. Unexplained recurrent miscarriages 6 times. This girl goes to one of our fertility care teacher practitioners, and the teacher says to her, I think your hormones are probably low. And the chart is crying that out because we have this abnormal bleeding pattern that you can see there. That's not a normal fertility care charting pattern. We could have told her before she had her first miscarriage, let alone her 6th miscarriage, you're at risk of miscarriage. She didn't know about us. Most physicians still aren't fully aware of what we do. She went through 6, but fortunately, despite being 40 years old, she still heard about us and came to us, and we were able to look at her chart, and our blood test showed progesterone was 35, which her GP told her is normal, which it is for day 21, but our target for her progesterone is 60, so it was low. So we put her on her hormonal treatment, without going into the details of all of the treatment we put her on, but we restored a normal appearance to her fertility care chart. And the bloods came within our target normal range. Our incidence of twins, by the way, is very low because we don't want to overstimulate or understimulate. We want to normal stimulate, restore normal physiology, which is what we did in her case, but she needed hormonal treatment in order to do that. So she conceived with an optimum cycle and got her positive test and had a lovely scan at 10 weeks. And we continued hormone support during her pregnancy, and she had a beautiful baby girl in March of 2006 at the age of 41, and her long time of all the things that she went through. She was 6 pounds 7 ounces, delivered by caesarean section, and thankfully everything went fine. Looking at our data, you could say, oh, well, everyone can wheel out an individual case. Well, I looked at a group of our most extreme group, that would be those who have had 6 or more miscarriages, and how did we do for these 4 years of practice between January 2004 and April of 2008. I didn't update it yet for this year. They were an average of 3.5 years trying to conceive, and their number of miscarriages ranged from 6 to 9. The reason I picked this group is because it's more extreme than just 2, 3 or 4 miscarriages. And the main figures to look at would be 77.7% of couples had a successful pregnancy if they were compliant with our treatment. But if a couple decided, well, we're not patient enough to wait until you complete the hormonal evaluation and until you give us the all clear, because we tell people, don't get pregnant until we find out what the problem is and we get a normal chart. For those who wait until we get the normal chart, we're going to get nearly 80% success. With 6 or more miscarriages, where you're looking at about 16% success for those who didn't have the patience to wait. Now, the numbers in this are still small, but you can see that there's a very large difference between the 2 groups, and if we get the optimum preconception environment, then we've the best chance we can help couples to get a successful outcome. Infertility with previous failed ICSI, this is IVF, where you inject the egg into the sperm, and this was done because of male factor infertility. This couple did IVF with ICSI twice, came to us at the age of 43 in April of 2007, never conceived naturally before, and she was 43, he was aged 38, and they'd been trying for 4.5 years. She had a problem with her pituitary, and she was on treatment for that, and there was also male factor infertility. And the only investigation she had done really was ultrasound, and because of the male factor, she was told when she first presented at the age of 39, go straight for IVF. 1 year of trying to conceive, straight into IVF. That was just the seminal fluid. And she produced 2 eggs, resulting in 1 embryo. The embryo was transferred and it didn't work. She had a repeat attempt at the age 40 in 2004, and again, the ICSI failed for her. So in addition to the male factor, normally you're going to produce about a dozen eggs. She only produced 2 or 3 eggs on maximum doses of treatment. So in addition to male factor, we also have premature ovarian failure. She was advised 3 years before she came to our practice, she was told, there's no point you doing IVF, it's not going to work. And 3 years later, she comes to us. Now, to be fair, with premature ovarian failure and her abnormal chart, her low hormones and male factor infertility, a couple that comes to me like that, I'm not going to promise the sun, moon and stars to somebody like that. I'd say, well, this is a tall order, and a lot of the time we will actually fail if we try in this situation. I rated their chances of success at probably 5%, given their overall history, but I said, well, we could still try and see how you respond to treatment. So I put her chart was quite abnormal, typical of what you would see with premature ovarian failure and approaching early menopause. And I put her on treatment without going into the details. Physicians that are in the group, I can make this PowerPoint available to you later on if you want to get the details. And we put him on treatment to improve his fertility. And we got a beautiful chart from her. She responded better than I would have predicted given her history. I put her on maximum treatment, all right, went straight for the top level of treatment. But we got lovely ovulation with a lovely looking chart, and everything was looking very good. And his semen parameters doubled. From a count of 40 million, it came up to 101 million. So the treatment we had him on was working very nicely. And they achieved a successful pregnancy in the 4th cycle of trying. In fact, her hormones were so high she could have had twins. Normally, we don't want to get the progesterone above 100. Hers hit 122 the cycle she conceived. That'll happen every now and again. They were normal for the 3 months prior to that, and then it just jumped. 2 eggs were released in the cycle of conception. But from my point of view, thankfully, just 1 egg was fertilized, because twins, there's more risk for babies as well as mum, and 1 is safer. So everything was great with the ultrasound scan, and she had a wee baby girl. Born in May of 2008, also delivered by caesarean section, 7 pounds 5 ounces. And the final case that I'm going to show you is the future pre-treatment.